Chapter 11, we're going to talk about childhood and neurodevelopment disorders. Right now we have 20% of children and adolescents who suffer from some type of major mental illness. When there's a disruption to the normal pattern of childhood development, this can actually cause issues academically, socially, and also within their psychological functioning. This disrupts the function and can cause a great significant stress on the family. Some families may not seek help or at least limit help from professionals because of maybe stigmas and misconceptions, and they even may want to conceal the condition. There's a lot of difficulty in diagnosing younger people due to limited language skills along with their cognitive and emotional development. There's a lot of wait and see in case there's just some type of developmental lag or an event that has maybe caused some type of pause or disruption. There's two main problems: the lack of services and premature termination of treatment, especially when it comes to vulnerable populations. There is a barriers assessment and treatment, and this is listed on page 182. These barriers and to assessment and treatment, these include the lack of consensus and clarity about conditions for how to screen children. Also, it lists that there's a lack of coordination among multiple systems. There's also a lack of community resources, and there's usually a large and long waiting list for these separate services. There's also a lack of health providers in the mental health areas, and there is also, we have to consider cost and inadequate reimbursements through health care for this as well. Disruption to normal pattern of childhood development can cause issues academically, socially, and in the psychological functioning. This disrupts the function and can cause significant stress on the family. Some families may not even seek help or at least limit the help from professionals because of stigmas and misconceptions. Or they may even want to conceal this condition. Difficulty in diagnosing younger people is usually due to some sort of limited language skills along with cognitive and emotional development. A lot of wait and see is around in case there might be some kind of developmental lag or an event that has caused this issue or this situation. There's two main problems. There's lack of services and premature termination of treatment, especially in your vulnerable populations. Then there's barriers to assessment and treatment, and these are listed on page 182 in your textbook. As far as the etiology, there's different factors. One of those is the biologic. This is usually genetics related to resilience, intelligence, and having a supportive environment can help in avoiding mental diagnoses. There's also neurobiological issues, which means changes in the brain. As far as the psychological, temperament, habitual behavioral ways that have been developed to how to cope with either some type of demand or expectations of the environment. Nurses can intervene to show parents ways to modify their behaviors to help to improve interactions, especially with adolescents. Also, if you remember from earlier, we have resilience, and that's the inborn strengths in in handling stressful environmental factors. And so they do list some characteristics. I think there's 6 of them that they list on page 183. As far as the environment, this can be modeled behavior by the parents, and cultural or differences in expectations, stressors, and the amount of support and of course all those can have a great effect. When it comes to the etiology, biological factors are your genetics. Genetics can be related to resilience, intelligence, and having some type of supportive environment to help in avoiding some of the medical diagnoses. You also have neurobiological, and this means changes in the brain. So some types of changes are going on or happening. Psychological factors, this can be temperament, habitual behavioral ways of how to develop or how we're developed to cope with demands and expectations of the environment. Nurses can intervene at times to show the parents ways to modify their behaviors to improve interactions with their children. We also hear resilience again. Again, that's that inborn strength in handling stressful environmental factors. They do list some characteristics on page 184 in your textbook. When it comes to environmental factors, these are behaviors that are modeled by the parents. Cultural, this could be differences in expectations, stressors, and the amount of support that they have, and this can have effect on them. Here we have a case study, and then on your other PowerPoint slide at the bottom, I do have the answers there for you, but I'd like for you to try to do it on your own before checking your answers. Here's a case study, and it talks about a child that has many risk factors for the developmental illness. So I want you to kind of go through this one and see what you can answer. And on the bottom of your PowerPoint for notes, the answers, if you look at the bottom online, you'll see the answers for these. And this continues on to this slide as well. And here's the second part. And like I said, try to answer it first, then go back and check your answers. When we look at assessing development and functioning, what is collected is going to depend on the agency's policies. Some of this is independent nursing judgment, which is used for determining what to assess and how to assess it. There's also physical exams that are also part of all serious mental problems. Data is going to be collected by interviews, screenings, testing, observing, and through interactions. The latter, you're going to ask about home, environment, teachers, and peers. And the interview is where you're going to start to build that trust and rapport. It's very similar to the adult mental status exam, and there is an example on page 185. The developmental assessment tells us about their maturational level. If it's abnormal, it could be related to stress, adjustment problems, or it could be a serious disorder. Those who have maladaptive coping behaviors, these will increase the risk of developing some type of mental disorder. What is collected will depend on an agency's policy. There's independent nursing judgment, and this is used to determine what to assess and how to assess it. Physical exams are part of all of your serious mental problems. Data is going to be collected by interviews, screenings, testing, observing, and your interactions. The latter, you want to ask about their home environment, their teachers, and their peers. The interview is where you're going to start to build this trust and your rapport. This assessment is very similar to the adult mental status exams, and these are on page 185. There's a section there. Developmental assessment, it tells us about their maturational level. Abnormal could be related to maybe stress, adjustment problems, or some type of serious disorder. Those who already have some type of maladaptive coping behaviors, this increases their risk for developing some type of mental disorder. There's several general interventions that are used for children with adolescents. When it comes to family therapy, these they have defined goals for each member to improve on or to work on, and this can improve to be useful. And they have some examples of this on page 186, and they talk about these in these sections here. When it comes to group therapy, play for younger, such as school-age kids, it can be very helpful in seeing how they react, how they cooperate, interact with others. And so there's different skills that are learned when it comes to the play therapy and how to get along, how they share, and then they have also other types of means to look at for adolescents, such as group discussions about personality or popular media events and different types of learning skills. When it comes to behavioral, these are some of the desired behaviors, and what we do is reward those to reduce the maladaptive ones. There's usually some type of a different system of points. So maybe they earn so many points for desired behaviors, and as this increases, they increase the level of privileges that they're going to be allowed to do as well. When it comes to cognitive behavioral, this is learning to replace thoughts that are negative and self-defeating with what is realistic, and appraisals and giving and receiving appraisals and helping to improve their functioning. This is very good for those who have some type of anxiety and depressive disorders. When it comes to disruptive behavioral management, you may have to do something such as a restraint. Although the restraint should always be gentle and safe, a safety issue. Someone also needs to be firm, but needs to be non-retaliatory, and it should be protective. In other words, protecting them and those around them. A release should be done as soon as that person is no longer deemed dangerous. If we give someone a timeout, it gives them a time for self-reflection or to allow them to get self-control. And then you have a quiet room, and this is an unlocked quiet room, just so where they can get away with some peace and quiet, and they're not being punished, but it's just a way for them to go when they feel that need or feel like they're going to just burst. They just need to go away on their own, and they go into a quiet area or room. General interventions that are used for children and adolescents. We're going to go over some of these in the next couple of slides. Family therapy. This is define goals for each member to help them to improve or to work on. This can prove quite useful, and they have a section on page 186. Group therapy. This is play for younger children or such as school-aged. They do have skilled lists on page 186, but it's having them looking how they relate to other children, how they learn to take turns, look at their temperament, and so forth through play. Adolescent groups usually discuss about personalities or popular media events, things on TV, shows, and they also deal with their different types of learning skills. Behavioral therapy, desired behaviors are going to be rewarded to help reduce the maladaptive ones. An example could be a point and level system. So a patient would receive points for desired behaviors, and as this starts to increase, the level of their privileges start to increase as well. Cognitive behavioral therapy is learning to replace thoughts that are negative and self-defeating with what is more realistic, and appraisals are going to help and improve that functioning. This is good for those patients who have anxiety and depressive disorders. Then we have, disruptive behavioral management. There's a few things under that. One of those is restraints. Restraints should be gentle and use a safe prompt, should be firm, non-retaliatory, protective restraints. The patient should be released from the restraint as soon as possible, and it should not be dangerous. This is a very fine line that you have to go on and be very careful, making sure that you are following policies and procedures. This should be done when someone is at risk of harming themselves or someone else. Timeout is where they go and for self-reflection or to get some type of self-control, depending on what the actions are. Versus a quiet room is where they go on their own. It's an unlocked room. It's very quiet, and they go just to get away from all the stimuli. Some other general interventions you'll see is the play therapy, and it helps to adapt to environment, helps them learn to control their impulses, and it's a way to help them to communicate. Bibliotherapy is using books to reflect on situations and feelings the child's experiencing, and they may even use like a journal as well. Therapeutic drawing, these are ways to express feelings and emotions that may be confusing. So they may use some type of art, therapy, paints, coloring, and especially with children, they will actually show their feelings on the page with the colors they choose and the way they're coloring. Music, this helps them to explore images and feelings inspired by music. The therapist usually has to help to guide the patient and select the music. When there's psychopharmacology, of course, this is medicating, but it should always be combined with another treatment. We can't rely completely on medications, so it's a two-way or a combination type of treatment. Then, of course, you always have teamwork and safety, using teamwork to help promote safety, especially those with those neurodevelopmental disorders that can be harmful or harmful to themselves. This isn't only with any type of violence, but not knowing any better, such as with your autism or Asperger's type of situations. When we talk about play therapy, this helps to adapt to the environment. It helps them to learn to control their impulses, and also ways to communicate. Bibliotherapy is the use of books to reflect on situations and feelings the child is experiencing. Sometimes they may grab books that deal or talk about feelings. Certain things, maybe a cover will get their attention, or they may do some type of journaling. Therapeutic drawing is like art therapy. It's ways to express feelings and emotions that might be confusing. So sometimes they color certain colors, or the way they're drawing it, or the colors, or how hard they're using the crayon or on the paper can also help them to express things that they just don't know the words for. Music therapy helps to explore images and feelings inspired by music. Sometimes a therapist will help guide the patient in helping them in selecting the music. Psychopharmacology is medication combined with another treatment. And this is the way most mental disorders should be treated. It should not be just medications alone. There should be some other type of treatment along with it. Teamwork and safety is huge. Using teamwork to promote safety with any of your patients with neurodevelopmental disorders. Some disorders can either be speech or language. If it's speech, they usually have problems making the sounds, and so they have what they call disturbed fluency. Either they do have a lot of repetition or hesitancy, and this impacts their ability to communicate. I know when I'm talking on the the voiceovers, I'm very aware of myself, and sometimes I catch myself doing a stutter or repeating myself, and I don't have a communication disorder. It's just trying to get my thoughts together. But someone who may have a stuttering issue can be an example of that. With the language, there's usually difficulty in understanding or using words in some in context or appropriately. Some children may have verbal or sign language communication, which is impaired, and some are just may have a difficulty following directions. With social communication, they usually have a difficulty in relating to other people. And this is usually one of the first things they use to rule out autism spectrum disorders if they have difficulty relating to other people. Two types of communication disorders can be speech and language. Your speech is when someone has problems with making sounds, disturbing, or they have disturbed fluency. They may do repetitions or hesitancy. Repetition could be stuttering, or someone may have hesitancy where they stop and they have to think how to perform words, and it actually interferes with their communication. So it does impact their ability to communicate. Language disorders, this is difficulty understanding or using words in the proper context or learning how to use them appropriately. This can be verbal or sign language communication, and both of those could be impaired. Or without being able to understand, they cannot follow directions. Social communication, this is difficulty in relating to other people. This is usually the first rule out for autism spectrum disorders. With some of our disorders, we actually have special education services, and these three that are listed here are three learning disorders that have where money and services go for special education. And this is with dyslexia, it has to do with reading, dyscalculia, which I think I have, is math, and then dysgraphia, which is written expression. Here's some of your learning disorders: dyslexia, dyscalculia, which I think I have, is math, and dysgraphia, which is, or graphia, which is written expression. Most of the special education services that are provided go to these learning disorders. Motor disorders, there's two types: stereotypic movement disorder and Tourette's disorder. Your stereotypic movement disorder is repetitive. They have purposeless movements for 4 weeks or greater. The diagnosis is usually determined by how severe they are affected and how they cannot perform or can perform their ADLs. We see this more with boys than in girls. The focus is on safety and injury prevention. They will also use behavioral therapy with this. Naltrexone is a medication that they use for these patients, and you can see some of the information on page 190. Tourette's disorder is usually your motor and verbal tics. We see this usually appear between ages 2 and 7, and it impairs their social and occupational functioning. Motor involvement is usually with the head. The torso and limbs can also be involved. It's usually permanent. However, there may be periods of remission. This disorder coexists with depression, OCD, and ADHD. They usually use behavioral techniques and medications to help control this disorder, and that is also on page 190. They have even been giving Botox injections to use to calm the muscles associated with the tics. They may also use Klonopin, Haldol, Catapress, or just a few of the medications that they use. Comprehensive behavioral interventions can be used to help them learn to more express themselves who have this disorder. There's 2 YouTube videos on this slide that you can view and that way you can have an example of what these disorders are like. Your intellectual developmental disorder, this is known as IDD. It's no longer called mentally retarded or MR. There's 3 areas of deficit, and it ranges from mild to severe. It can also be associated with other disorders like autism spectrum disorders. And they do talk about some of these IDD on page 190. They usually have deficits in reasoning, problem solving, planning, judgment, abstract thinking, and their academic ability. They can also have difficulties with social functioning, such as communication and language and learning how to interpret and acting on social cues and regulating their emotions. It also can affect them in managing their daily activities, schoolwork, work, and performing just everyday self-care. Autism spectrum disorder, this is a complex disability in neurobiological and developmental disability. It affects parts of the brain for social interaction and communication skills. It can go from mild to moderate to severe. Socially, it involves communication, nonverbal behavior, and age-appropriate interactions. There has been found to be a genetic component of this where it is passed on from one family member to the other. Lots of times when it's mild, usually maybe Uncle Joe was always just a little different, and so he was never really diagnosed. And so then but my cousin Billy, who is the son of Uncle Joe, Billy's always been a little different or a little odd, but they thought, well, they all live in the same household and they're all together, and maybe that's what the issue is. Now, when it's moderate or more severe, then of course, that's when people go for help or assistance and get that diagnosis. At the end of this slide, you'll see there's a YouTube video on here. You want to assess for repetitive speech, use of objects, routines and rituals, fixations on objects, hypo or hyper reactivity to different types of sensory input, and extreme resistance to change. You want to also, in your book, look at the assessment guidelines. There's also a table, 11-1, for potential nursing diagnoses. For implementations, you have your psychosocial interventions. It's very important, the earlier the better, to have early intervention programs, therapeutic schools. They're going to work on behavior management and a reward system, speech and occupational therapy if it's needed. Your psychobiological, they may use a psychotropic such as an SSRI to improve their mood and decrease anxiety, to help them or to assist them with the tolerance of situations. And then in the end, you're going to do an evaluation of these individuals and see how well they're getting along, checking with the family members. And again, family members, when it comes to this, need to have a clear and realistic expectation of the long-term needs of this child. They also need to be linked with appropriate health care and community resources. Evaluation measurements should include access to the timely and effective and efficient provision of all needed support services, the family's awareness of how to advocate for appropriate provisions as well, or service provisions for these. As I said, this can go from mild to severe. So depending on how severe, it does affect more boys than it does girls. And again, they do not like changes, and any kind of change in routine can lead to a tantrum. And you'll see in this video a young man who has autism spectrum on the severe level. When it comes to ADHD, these children and adolescents may have this without hyperactivity, which might be ADD, attention deficit disorder. Symptoms must be present in two settings, and that's the home and the school. And it's usually seen before age 12. Lots of times it's picked up when the child is having difficulty adjusting to school. They may have a low frustration level, a low frustration tolerance, temper outburst, or they may have a labile mood, poor performance in school, peers will start to reject them, and they can have a low self-esteem. Many times these individuals will have trouble taking turns and maintaining social relations because of their high level of impulsivity. They interrupt frequently, they have poor social boundaries, and many times they can become intrusive. They're distracted easily, disorganized, usually unable to complete challenging tasks, become easily bored. They can lose things more often, and lots of times they need prompting to complete a task. There is an assessment guideline on page 193, it's a little green box, and then there's a table 11-1 for different types of diagnoses that you might see. Then we have the outcomes, and again, this can be learning how to, outcomes can be targeting their hyperactivity, impulse control, helping them to identify their self-identity, self-esteem, showing them positive coping skills, and different types of family functioning and being part of the family. For the implementation, we have your psychosocial interventions. You have psychostimulant. This is to help them to control aggressive behaviors. They may be mood stabilizers, adrenolytics, antipsychotics. However, we have to look and pay attention to the risk of tardive dyskinesia. And also cognitive behavioral therapy is very helpful. Psychobiologic, we look at Adderall and Ritalin. However, side effects are insomnia and weight loss. One of the things that we were finding out is that Ritalin became the drug of house moms who stayed at home, or moms who were single parents and trying to keep up a household and work. They were using their children's Ritalin to help them keep going. Hence, it causes insomnia as one of the side effects. So they thought it would help them keep going. And also, women were also using it to lose weight. So they were actually stealing their children's Ritalin to help them keep going. Here's a slide here about Rett's disorder. And again, these children have normal development for the first 5 months, and then they start to have some different deficits in their developmental maturation, and they have some developmental delays. One of the major signs is the small head. Their head actually starts to decelerate with growth, and they also start to lose different functions such as motor functions, speaking, and their language skills, and they have impaired language development, which becomes very severe, and some don't even talk. Sometimes some of their symptoms can actually look like autism. They do have mental and social developmental regression, and so they become more like a 1 or 2 year old as they are in maybe ages, 4, 5, 6 years old. I've got a video here for you to see a little girl and how she communicates with a new method that's out there. And again, we have another case study, and I'll let you look at that and then check your answer. I have a couple of disorders that are listed up on these slides, and just some basic information so you have an idea what they are. This is disintegrative disorder, very similar to the Rett's and autism. They have difficulty with language, and they have different difficulties with their social skills. They have poor control over their bowel and the bladder, and they have difficulty playing, and because of that lack of social skills. And it's very similar to the Rett's and the autism. Asperger's is similar to autism. These children and adolescents have problems with social interaction. They have either some type of restrictive or repetitive motions, behaviors, whether it's through speech or through actions. They do have some delays in their development. However, they still have a lot of their basic skills. What really stands out about them are their social skills and their difficulty with communicates. Sometimes they're very smart in how they speak, and they'll sound like, as I sit here, sound like little professors. Some of them have a little bit odd. They just seem different. Remember I was telling you about, Uncle Joe with the autism. Same thing with the Asperger's. No one ever diagnosed this person, but they always knew there was something different about Uncle Joe. Sometimes they can be bullied because other kids don't understand, they're different, and so they can be bullied in school. They may ask the same question over and over and be fixated on one thing, and so other kids may pick on them or tell them, like, shut up, just stop. And it's because they don't understand how these individuals think. Social interactions can make them very uncomfortable. You may even hear stuttering. They may have to leave the room because there's too much stimuli around, and so they know that they need to leave a room to calm down, and sometimes they'll talk to themselves. Here's a list of how it's different from autism. Again, there's no delay in language or cognitive development. They just have their pace, and they don't have a lot of the words that we do. They are more age appropriate in self-help and adaptive skills, if allowed. And that depends on the parents. Sometimes parents see something's wrong and they do more and more for this child, and it actually makes them behind, and it's not because of their disorder, it's because the parents' protective mode or think that they have to do everything for this child. They do want to be involved, they want to be a part of things, they just have trouble socializing in big groups. We do see a little bit later onset of this than we do with autism as well. So look at this YouTube video of a child with Asperger's. I wanted to bring back up attention deficit hyperactivity disorder, ADHD, because I did want to go over some of the inappropriate degrees of activities and how they react, such as the inattention to inattentiveness, hyperactivity, impulsivity. Lots of times students will ask me, well, what's the difference between that and some of the Asperger's because of the way they react? ADHD, they're just like you and I. They just have problems with paying attention, especially being able to focus and sit still. They're very hyper, so they'll start to fidget and they like to run around, especially children. They'll get up running and they go to bed running, it seems like. They're also impulsive, so they don't have that self-control. But they could once they, but they don't have any developmental delays, such as the other disorders. This slide, I do have a little video here as well for hyperactivity disorder, and just going through a nursing process with one of the disorders. So I did use the ADHD for this one. And so looking at your assessment, how active are they? Can they pay attention? Are they just a little motor mouth, just going? What are their social skills like? Do they have other issues or comorbidities, such as problems with their conduct? Are they defiant to adult figures and authoritarian figures? And as I said, you can look at this video here. Also, to coming up with the diagnosis. What would be the diagnosis? And a lot of times it may be safety, might be your primary diagnosis. And then what is your outcomes? And you have to be very realistic, especially when it comes to disorders with the children. And then implementation. What are we going to do? Let's do a little bit of medication, but let's also do some psychotherapies as well, and blend that in there and put it together, teaching them how to wait their turn, not to speak out of turn, not to be impulsive. So here we're going to use medications, but we're also going to use some type of psychotherapy along with the medication, and then evaluate: is this working? Is it not working? Do we need to continue on a little longer? Another disorder is conduct disorder, and this is behavior that is just, they're overstepping their bounds. They just have problems. They're just that little, reminds me of, those little kids that you see in some of the movies that try to make them the villain, and they're always he, and always trying to do something that's not right, and they're getting in trouble, they're tearing things up, they're mean to other kids, they're physically, aggressive towards others, I don't care, and they think it's funny when they hurt the feelings of someone else. And all in all, what we find out is lots of times they have a low self-esteem, and it's under that facade of toughness. They're going to act tough because really deep down inside, they have a low self-esteem. And so when they show that little empathy towards others, it's because that's how they feel. Your oppositional disorder, this is hostile behavior towards authoritarian figures, teachers, adults, and again, they have the same aggressions and destructive behaviors, just like conduct disorder, except it's towards authoritative figures. So anything they say, they're going to do the opposite. Lots of times we see this in early age, around age 8 actually. So when you look at some of the characteristics and some of the antisocial behaviors of those with the oppositional defiant disorder, we see that negativity, disobedience, the hostility, defiant behaviors, especially towards the authoritative figures or authority figures, stubbornness, argumentative. They have a limited. They limit to test it. They push things to the very limit. Unwillingness to compromise. They refuse to accept responsibility for their misbehavior. It's usually demonstrated at home and directed towards the person that they know the best at home and that they're around the most. And they view their behavior as a response to unreasonable demands and circumstances in the house. And also, too, they can actually develop into conduct disorder as well. So they can actually start off with this oppositional, but then they can go to just plain old conduct disorder as they age. This slide pretty much says it all with psychopharmacology, and again, actions and side effects are going to differ between children and adults. So we have to think about all those, the developmental considerations, and also find out, does the benefit outweigh the risk? The most frequently prescribed to treat ADHD are up here on this slide, and however, we have to be concerned because some of those may affect their growth. And then here's a list of the non-stimulants as well. When it comes to your medications, we need to look at the dosage and the timing adjustments, because this is going to be critical for effective management. Also, the dosages need to be titrated slowly to be able to achieve the lowest satisfactory dose. We don't want to over-medicate these children, so we want to see what is the lowest dose that will get the effect that we need. And then here's some of the therapeutic effects of your stimulant medications. And here's the other slide talking about your stimulant medications. And as you go through, you can go through these slides and look at the questions. And then the answers, of course, are listed on your speaker notes and your PowerPoint notes, note slides. And here's the next one. And the last one.